Hello everybody, it's so nice to be back with you again, especially since I've just recovered fully from a bout with COVID infection. It wasn't fun, I can tell you, but fortunately I'm back on the saddle again, ready to go. The topic today will be tubal disease and IVF. So today we're going to talk about, firstly, the causes of tubal disease, and we're going to talk about how IVF fits into this equation. First of all, let me say, by and large, with few exceptions, when we talk about tubal disease, we are referring to blocked fallopian tubes. And when fallopian tubes are blocked, they're usually blocked at their ends, although they can be blocked where the tube leaves the uterus. They're usually blocked right at the ends. When they're blocked right at the ends, it is almost always as a consequence of previous pelvic inflammatory disease, and the most significantly causative organisms are Chlamydia and Gonococcus. These are both sexually transmitted diseases, venereally transmitted, and they travel through the cervix to reach the uterine cavity and then the tube, and then down the tube, and they cause inflammation inside the lining of the tube, which disrupts its normal function, which is to allow easy transport and nutrition of the egg and the sperm and embryo as they pass up and down the tube. And then they get to the end of the tube, and like anywhere else in the body, when there's pus that develops due to inflammation in an area, the body tends to try to wall that off. And the way it does it is by blocking or ensheathing the area with fibrin and scarring. And that's what happens at the ends of the tubes. The finger-like projections at the ends of the tubes fuse together, fold, and to try to contain the infection within the tube. And this then can result in the tube being completely destroyed, as such that you can't even see any dye entering in it, or usually, much more commonly, when you do a dye X-ray test on HSG, you see the dye go through the tube towards the end of the tube and then be blocked at the end. Sometimes the pus that collects in the tube starts attracting fluid into it and the tube distends. We call that a hydrosalpinx. And the hydrosalpinx means that the tube has been completely destroyed. There's no point in even trying to consider restoring it. But it also means that you have to be careful, because when you do IVF, that fluid can drain back down the tube into the uterus and damage the embryo that's trying to attach. Now, a few words about tubal disease, and most specifically how it relates to pelvic inflammatory disease. Let me give you how the scenario works. When a woman becomes infected with gonorrhea or chlamydia, and those are the two most important ones to consider, can happen with rare organisms like tuberculosis, Mycobacterium tuberculosis, but we don't see much of that in the United States. It's more confined to other countries, third world countries, and especially in Asia. But in the United States, we don't see tuberculosis of the pelvis much. So the bottom line is that the infection is introduced sexually by the man into the woman's vagina, and then it first infects the cervical opening. As you know, the cervix is like telescoped into the vagina, and there's a little opening through which the menstrual flow goes as well. And of course, that's the opening that stretches wide open as the baby comes through at birth. That infection then causes what we call an initial cervicitis, which means infection of the glands of the cervix. That may or may not be symptomatic. It's interesting that that part of the cervix lies juxtaposed to the base of the bladder. And there are connections between the cervix and the bladder's surface inside, lymphatic connections. So that if the cervix becomes inflamed, the toxins can pass via these lymphatic channels to the base of the bladder, causing symptoms that are indistinguishable almost from a bladder infection. Things like urgency to get to the bathroom, frequency of urination, and sometimes discomfort and pain. These symptoms will tend to make the average physician who does an evaluation of the woman who comes to his office because of these symptoms, the doctor will often make the diagnosis of a bladder infection and just issue the woman sulfurs or certain types of urinary antiseptics to get rid of the infection without making a definitive diagnosis. Herein lies a major problem, because if the doctor treats it as a bladder infection with things like sulfurs and even certain antibiotics, it will not be sufficient to get rid of an infection in the cervix, because these urinary antiseptics don't kill the bacteria in the cervix. They only would render the urine sterile, cause the urine to be the antibacterial effect in the urine, so that the bladder itself and the symptoms disappear. Here's why that's a problem. The doctor will miss that the woman has actually got a cervical infection, which is the start of the effects of pelvic inflammatory disease. And in the process will undertreat the infection, and it will drive it underground, so the woman's symptoms may not be as overt, as clear, that drives the doctor to believe she's got pelvic inflammatory disease as it expands and evolves. The only way to be sure is to test the urine, to look for bacteria in the urine, to culture the urine, and to culture the woman's cervix. And unfortunately, most of you ladies know that when you call up your doctor and you say, I'm having frequency of urination, and I have a strong urge to go to the bathroom, and when I urinate it burns, and I'm feeling a little bit of lower abdominal pain, the doctor will immediately jump to the conclusion that it's a bladder infection and say, okay, I'm going to call in some urinary antiseptics or sulfurs, which are sufficient to render the urine antiseptic and get rid of a bladder infection, but are not sufficient to kill an emerging pelvic inflammatory disease, which will get to the tubes. I urge you, therefore, if you have symptoms such as these and you go to the doctor, don't settle for that answer. Make sure the doctor cultures your urine, examines it under the microscope, and cultures your cervix for gonorrhea and chlamydia. So the infection starts at the cervix, then it passes via the cervical canal to reach the uterine cavity. Now, under normal circumstances, you'd expect an inflammation to occur inside the uterus. That rarely occurs with gonorrhea and chlamydia, because most women menstruate regularly, and every month when they menstruate, they purge the uterine lining, and that gets rid of the infection in the uterus. So it's almost never that when you see scar tissue inside a woman's uterus as an indication of infection, that it is due to chlamydia or gonorrhea or a sexually transmitted acute infection. It's usually due to something more serious, and something that's usually occurred for reasons that we'll discuss in a few moments. So the infection goes via the cervix, causes some symptoms. Sometimes a woman has a little bit of lower backache, has a discharge which is non-irritant but can be malodorous, and it will cause those kinds of symptoms. Sometimes she'll have lower abdomen pain, but rarely at this stage of the early infection will she have fever. The inflammation will then travel from the uterus through the opening of the tube into the fallopian tube, and that's what I described later. When it gets in there, it's like a forest fire. It disrupts the normal anatomical folds in the uterus that run all the way from the opening of the tube all the way to its ends, allowing currents and countercurrents and secretions to be produced by the cells that are necessary to nurture the sperm, the egg, and the embryo. What happens is this inner lining of the tube, we call the endosalpinx, becomes inflamed, and this gets permanently damaged. It has no ability to regenerate, so once it's been damaged, it's been permanently damaged. And then the infection can go into the wall of the tube and compromise the ability of the tube to be motile and to propel the egg and the sperm and the embryo in the proper directions that they need to go with at the appropriate time. So the tubal wall can be damaged, and when the wall is damaged, then the tube is really been permanently damaged. And especially, as I mentioned earlier, when it gets to the ends of the tubes, and the end of the tube, the fimbrial end, the petals, fold over and block the ends of the tubes, that usually renders the tube permanently non-functional. And here's the message. In such cases, if you go in and you, at a later stage, and you try to open up the tube, you're opening up a functionless conduit in most cases. That means that the tube won't function properly and won't propagate a pregnancy. That is why women who've had pelvic inflammatory disease with tubal damage, as evidenced by a dye X-ray test called a hysterosalpingogram, or laparoscopy, which reveals the ends of the tubes to be damaged and adhesions and scarring to be inside the pelvis from the leakage of inflammatory material, pus. Such women, if that gets opened up surgically, will have no more than a 2 or 3% chance of getting pregnant per month, and probably no more than a 20% chance of a pregnancy occurring within the few years. That is why the performance of tubal surgery for damaged tubes secondary to pelvic inflammatory disease is a complete and utter waste of time. Today we don't do that anymore. Today we bypass the damaged tube completely. We do in vitro fertilization. We remove the eggs from the ovaries, fertilize them, and then put the embryos inside the uterus through the cervix. So with a normal course of events, when a woman gets this process I just mentioned, starting at the cervix, through the tube, through the uterus and into the tube, if that is unchecked and nobody gives the woman urinary antiseptics through the misdiagnosis of a urinary tract infection, or they're not started on antibiotics, this infection will become acute. The woman will develop a severe abdominal pain, a tender abdomen. She'll not be able to move around easily. It'll be very, very painful. She'll have fever. She will be sick. And in most cases, such women will go to their doctors and say, look, do something. I'm obviously very, very ill. And the doctor will put her on usually intravenous antibiotics or oral antibiotics, usually intravenous if it's very severe, to prevent complications from occurring from this condition. So the important point to understand here is that pelvic inflammatory disease can mask itself in many women as simply a history of urinary infections, which, as I said, weren't really true urinary infections. But if the woman has this acute presentation with lower abdomen, fever, and a vaginal discharge, and backache, and all this pain that goes along with it, such women will usually be treated and may get through it without permanent damage to their tubes. Unfortunately, in first world countries like America, the doctors are always too ready, too quick to start a woman on urinary antiseptics as if the diagnosis was a urinary infection, and drive this whole thing underground so it smolders and you don't even get these symptoms, and the next minute the patient comes to the doctor to be evaluated for infertility, he finds her tubes are blocked, or does a laparoscopy and finds scar tissue outside the tubes, binding them down to surrounding tissues as a consequence of inflammation. So this is the way in which acute pelvic inflammatory disease can compromise fertility through the tubes being damaged. If there's a hydrosalpinx, as I mentioned, where there's fluid inside the tube, it's a good idea to remove that tube, or at the very least to ligate the tube as it leaves the uterus to avoid that fluid draining back into the uterus and preventing success with IVF. So this is the commonest cause of tubal disease. Of course, the other problem that occurs if you try to fix that tube and open it and help the woman get pregnant through natural means thereafter, besides the success rate being extremely low, is the fact that the tube is damaged, so the embryo, the fertilized egg, get stuck in the tube, start to grow there and form a tubal or an ectopic pregnancy. And this can cause the tube to rupture. It can be a life-endangering condition. So in my opinion, if there's evidence of tubal disease, and especially if there's a suggestion from the history or the findings that this is due to inflammation, the treatment is to do IVF, and if there's a hydrosalpinx, to remove or block that tube as it leaves the uterus to avoid the complications that I mentioned earlier. Now, there are also other causes of tubal disease. This can occur when the inflammation didn't start from the cervix with pelvic inflammatory disease, gonorrhea and chlamydia, but rather started outside of the uterus. This can happen after an acute appendicitis. It can also happen if there's inflammation in the bowel, which spreads outside the bowel to cause scarring around the tubes. But the common one to be aware of is damage that can occur after a pregnancy after a pregnancy. Let me give you an example. Ordinarily, when a woman gives birth to a child or has a miscarriage or even an abortion, all the products that were in the uterus are expelled. Sometimes, however, these products aren't completely removed, or some of the placental tissue remains behind after the birth of a child, or there is some evidence of tissue that was there from a previous miscarriage that was incomplete remaining behind, and that tissue can become what we call necrotic. That means it dies. Why is that important? Because there are bacteria in the vaginas of many women that are called anaerobic bacteria that can only grow in the absence of oxygen. And if a woman's given birth to a child or had a miscarriage or an abortion, and not all the tissue was removed or came away, then some tissue will remain behind and be dead, and these bacteria can then flow up through the cervical canal back into the uterus, habit the dead tissue, and result in inflammation. This will cause scarring in the uterus because after the birth of a child or after a miscarriage, the woman doesn't usually have a period immediately. So the inflammation will spread in the uterus, can cause scarring that can range from a few bands of tissue all the way through to a complete fusion of the wall of the uterus together. So the woman has diminished or absent menstruation. We call that an Asherman syndrome. But the most important thing to take away from this is the following. If the inflammation occurred after the birth of a child or after a miscarriage or abortion, because the doctor didn't evacuate the uterus properly or didn't confirm that the uterus had evacuated spontaneously completely, that inflammation can permanently damage the lining of the uterus, rendering it incapable from thickening adequately during the cycle or during stimulation with IVF with the estrogen. When this happens, the lining is usually less than 8 millimeters in thickness, and the woman has got a problem that may be permanent, and there may not be a lot you can do about it in some cases. Treatment is to try to make sure the uterine cavity is clean and cleared, but also to try to use something like vaginal Viagra, which improves blood flow through to the uterus and enhances thickening of the uterine lining and improves the ability of an adequate implantation base to form in the uterus. But this is a problem one. So when a woman has got scarring in the uterus, or when the lining fails to thicken and there's a history of a previous miscarriage or perhaps some symptoms suggesting previous endometritis, which is the inflammation that occurs following on, or we call it postpartum or post-abortal or post-miscarriage endometritis, if there's some suggestion that that happened, it's very important to be sure and then inspect the uterus carefully inside. If there's scar tissue, try to remove it to see if that improves matters. Sometimes it will, but most times it won't, and you're stuck with a big problem. If you can't fix the problem through the use of vaginal Viagra or the use of estrogen therapy and even the use of medications like antiprostaglandins, aspirin and things like that, then what often happens is you're left with no alternative but to consider the ultimate option, which isn't something one wants to really contemplate, but it needs to be considered in such cases, and that's using someone else to carry your baby or the use of a gestational surrogate. Now, there are other causes of the tube being damaged. It can be damaged when there's surgery done. Some women go through surgery to remove fibroid tumors from the uterus or to remove tumors or cysts from the ovaries. Such surgeries can cause irritation of the surrounding tissue, resulting in adhesions that bind the tubes to surrounding organs and prevent the normal passage of egg and sperm. In such cases, if you compare with what I told you earlier, the inflammation starts from outside. So that means that the inside of the tube is often quite normal, and in those cases, surgery to free the adhesions and make the tube more motile and mobile may work. In such cases, it's especially those cases where the tubes are opened by hysterosalpingogram and the finger-like projections of the tube haven't fused together to close. Once that's happened, you really don't have much chance surgically of doing anything. So in summary, when there's tubal damage, it's usually secondary to pelvic inflammatory disease, venereally transmitted with gonorrhea and chlamydia, and I've discussed that with you. The problems are that when that happens, the inner lining of the tube can be permanently damaged. The finger-like projections that pick the egg up off the ovary are fused, and surgery is a waste of time. The second cause of pelvic inflammatory disease, tubal disease, is where the inflammation starts inside the uterus, following on the birth of a child and or miscarriage or abortion, where some of the tissue is left behind. This is one of the reasons I tend to favor making sure if a woman's miscarried that the uterus is empty. I do an ultrasound, and if there's even a suggestion of any tissue left in the uterus, I go in and evacuate it before it can become the source of an anaerobic infection and scarring in the uterus that can be permanent. So in that situation, the inflammation can pass through the tube again to the outside of the uterus and cause scarring. If the scarring has occurred only outside the tubes, surgery to free those adhesions can sometimes be of benefit. And in other cases, when there's been damage to the tube, you've always got to be concerned about the possibility of an ectopic pregnancy, which can be life-endangering. So if a woman's had pelvic inflammatory disease, she's not only at risk of infertility, but she's at greater risk of having an ectopic pregnancy should she conceive. And this needs to be addressed and needs to be treated appropriately in order to prevent those things from happening. Now, the difference between, as I told you, doing tubal surgery, which is today of interest only from a historical point of view, in my opinion, versus IVF, is that with tubal surgery, the chance of getting pregnant, as I said, is probably 2 to 3% per month if the tube is rendered patent. And it is as high as 40% or even 50%, depending upon the age and the ovarian reserve of the woman, if you revert to IVF, provided if there is a hydrosalpinx, you've dealt with it as I've described earlier on, before you do the IVF. There's one other cause of tubal disease which needs to be just mentioned over here. Some women go through a procedure called tubuligation, where they get the tube purposefully snipped and blocked to prevent future pregnancy. It's a highly effective way of achieving contraception. And it can be reconnected sometimes, but again, the chance of success is so much smaller than with IVF per month of trying that, in my opinion, even tubal reversal after previous tubal ligation is not a good idea. It can be contemplated if the area that was ligated was very small, and reconnecting the tube by excising the area that was blocked off surgically brings the tubal ends into close apposition. But sometimes so much of the tube has been damaged that you cannot bring an equal size on the one end to fit easily with the proximal end that you excise. So you end up with a poor fit, and that results in poor results. So tubal surgery for previous tubal ligation is, in my opinion, also something that should no longer be considered. IVF is a far better approach. And I'd mentioned earlier on tuberculosis. I don't want to go into any detail about pelvic tuberculosis, but when it damages the tube, those tubes are gone. And if the uterus has also been affected, there may be even a bigger problem with the receptivity of the uterine lining. But if tuberculosis is diagnosed, it requires months and months of treatment with appropriate medications, rifampin and various other isoniazid and even streptomycin, which isn't used much anymore, but there are some newer drugs that can be used for prolonged periods to get rid of the infection completely. So I just wanted to share this with you today, and for those of you that have heard this live feed and are interested in talking to me directly, might I recommend that you call my assistant, Patty Converse, at 702-533-2691 and have her set up an online consultation with me, or go directly online to my website at sherivf.com. When you get there, you'll find an application form that you can fill in starting on the home page, and you can fill it in, submit it, and leave your phone number, and Patty will get back to you and set you up with the consultation. Those of you who want to email Patty directly can do so by emailing her at concierge@sherivf.com. CONCIERGE @sherivf.com. I thank all of you for listening. I hope you found it to be helpful, and I look forward to speaking to you in person. God bless.